let's just wait a couple more minutes so people log in, and then Marilia can explain everything, and we will figure out how to make sure people choose the appropriate channels and get going. And Sue, I know you talked to Marilia about it. And I think some people I know will try to listen to the lecture in English. So I know you well, and you're not a fast talker, but if you could just keep the pace reasonable, so the non-native speakers can follow you, we would very much appreciate. Although
my pleasure. I keep telling myself, slow down, drink some water. Yeah.
Look at Maria's happiness.
Yeah. And hopefully my hands, I tend to, like, you can tell I'm Serbian, my hands go all over the place. So.
But that's actually very nice, because one thing from like these online like lectures is that people may feel a little disconnected. So seeing you getting more or less excited. See, I'm talking and I'm moving my hands.
Yeah, I can't do it without moving my hands or back and forth. Sometimes I think I make people dizzy, but so, yeah.
No, I don't think you do.
Yeah.
Let's just wait a bit more. Pessoal, quem tiver coragem ou vontade, pode fazer que nem a Glaucia. A Glaucia deixou a câmera dela aberta, com um background bem interessante. Igual, não tão interessante quanto o Dani anda, mas razoável. O Alex está com um futuro colega participando já ali. Muito bem.
Sweetie.
Muitíssimo agradecido.
Hello, everybody.
Hey, Alex. Alejandra, Emílio. Milton, muito obrigado. Tá. I think we could get started. Are you guys good to get started? You good, Sue?
Whenever you want to.
Ok. Marília, você quer explicar para o pessoal como é que é o esquema dos canais? E daí eu apresento ela formalmente e daí a gente toca. Tá.
Certo. Então, eu não liguei ainda, porque a partir do momento que a gente ativa os canais de linguagem, só quem tiver no mesmo canal que eu consegue me ouvir. Então, no momento, vocês não vão estar vendo as opções para a linguagem. Assim que eu ativar, eu vou estar no canal em português. Então, só quem tiver no mesmo canal marcado português vai conseguir me ouvir. A gente vai pedir para vocês escolherem ou o canal em inglês ou canal português, que são as duas opções que vai ter. Tem também um canal geral. Esse canal geral a gente vai pedir para ninguém ficar nele. Então, escolha ou português ou inglês. A palestrante vai estar no canal em inglês, eu vou estar no canal em português fazendo a tradução para vocês, certo? E aí, a partir desse momento, a partir do momento que eu ativar, aí vocês vão ver que vai aparecer essa opção para vocês na tela. Então, escolham ou um ou outro, tá certo? Alguém tem alguma dúvida quanto a isso no momento? Enquanto vocês ainda conseguem me ouvir? Beleza. Então, eu vou ativar aqui. So, I'm gonna turn on the language channels now. You can go to the English one when they appear.
Okay. Okay. So, do you want me to go ahead and get started?
I just want to do a quick introduction.
Okay. Sure.
So, Marília, melhor apresentar, eu apresento em inglês, você traduz? Pode ser? Ou, apresento em português, pronto. I'm going to introduce you in Portuguese, so
That's
like...
fine. I know who I am. You go ahead.
Tá bom. Perfeito. Tá. Pessoal, bom, todo mundo sabe da importância do tema, e é exatamente pela importância do tema e ter... A doutora Sue Wagner, ela é diplomada, né, do Colégio Americano de Neurologia, então ela tem toda a certificação de neuro, passou pelos 3 anos de residência, tudo isso. Só que nos últimos anos, ela é, vamos dizer, uma neurologista alternativa, no sentido de que ela deixou a atuação dela tradicional de neurologia, neurocirurgia, e se dedica, né, às terapias de verdade alternativas. Quem leu a biografia dela pode ver que ela é coautora, né, de um livro, né, através do ouvido de um cão, né, que é tipo de terapia com som. E essa terapia com som, na verdade, ela é bem usada nos Estados Unidos. Ela trabalha com campos energéticos e com fitocannabinoide. Então, ela, tipo, para nós, né, eu sou mais um neurologista ordinário, tradicional, vamos dizer assim, a gente, né, pergunta para ela a opinião dela, o que ela acha sobre esse tema, porque ela, obviamente, é mais qualificada para falar disso que uma pessoa como eu, que tendo a usar mais as terapias mais tradicionais, né, e tipo como a maioria dos neurologistas norte-americanos, tá? E ela é professora adjunta na Ohio State, mas nessa área de terapias alternativas, e ela trabalhou em Columbus. Tem 2 grandes hospitais, tem o Ohio State University e tem o MedVet, que é tipo tão grande quanto o Ohio State em termos de especialistas, e é um baita no hospital. Uma cidade de 2,3 milhões de habitantes tem 2 hospitais só, e ela trabalhou por muitos anos nesse outro hospital. Tá bom? Então, é com grande prazer e com grande felicidade que eu tenho o prazer de apresentar a todos, né, a doutora Sue Wagner, para falar de bases terapêuticas dos fitocannabinoides. Sue?
Okay.
Your turn.
Okay, thank you so much. And thank you everybody for being here this evening. I really, really appreciate you inviting me to do this. And I'm going to go ahead and share my screen so we can watch a little PowerPoint. Okay. So hopefully that's showing up for everybody. And I apologize if you already know about the endocannabinoid system, because if I recall, we kind of talked about this a little bit before, but I wanted to be sure that everyone was on the same page. So hopefully it's okay that I do a little introduction of what the endocannabinoid system is, and then we'll build into what its importance is in seizures, and then build into the treatment using the endocannabinoid system and legalities and controversy and all of that. So the first part of this is really defining it. And to me, you know, I really blew this off for many years. I just wasn't all that interested until I think I watched a webinar or I read something. And when I realized its importance for the nervous system, I thought, man, I better sit up and do some reading. And it's an absolutely fascinating, very simple yet complicated system. And it's made up of receptors, of the ligands, you know, the substances that bind the receptors, and then the enzymes that synthesize and degrade them. That's the entire system. Now, what makes it unique is that it is embedded everywhere. So, you know, we tend to think of systems, you know, nervous system, cardiovascular system, they all have their organs and, you know, how they are connected, you know, the brain to the spinal cord and all of that. Well, the endocannabinoid system is literally embedded everywhere. And that to me makes it fascinating and unique. Now, when you do reading about it, the two main receptors, cannabinoid receptor 1 and 2, are the main ones that people talk about. But as you see, as we go further into the presentation, you're going to see that there are far more receptors, and it's far more complicated than that. But for generalities, CB1 is very predominant in the nervous system. It's a lot of different places, but very predominant in the nervous system. CB2, while it is also in the nervous system, is predominantly with the immune system and other systems. And its real function is about immune regulation. So some of the other receptors, just a few that I think are important to talk about tonight, are these three: the TRAPV1, GPR55, and PPAR. And the one that is most important that I would invite you to read about is the TRPV1. Not so much for the seizures, even though it's important, but is critically important for pain modulation. And so much good research is going on right now with this receptor. So there's going to be more and more coming out. So I would invite you to kind of follow that. It's really fascinating things. But these three receptors also play a role in what we're talking about this evening in terms of seizures. So I think everybody knows this by now. It's made its way into social media. CB1 receptors, as I said, predominantly are in the nervous system. And the difference between many species and dogs is that dogs have more receptors, more CB1s in the cerebellum and the brainstem. And because THC, which is part of cannabis, we'll talk about that later, really binds so completely to CB1, it makes dogs more susceptible to having side effects to cannabis. And so that's where the static ataxia comes in. You know, they get into the medical marijuana of their owners, and it's, you know, we've probably all seen it. Very classic. And the interesting thing to know, though, is that there's no LD50 for THC. They couldn't do it in mice. They couldn't do it in dogs. And it is non-addictive, meaning that receptor binding that you see with opioids and other drugs that would actually bind in the nervous system and be addictive. Yes, it's habit forming, but it technically is not addictive. So the dogs that have died from getting into THC have been because they've been so stuporous that they've aspirated. There was a recent news report out of another group of dogs they're tracking. Sure. No, it's okay. I'll go ahead. Okay. Another group of dogs that died, however, it may be related to what was actually in the products, you know, the candy type of THC, xylitol, other things that were toxic. So the ligands, there's two main ligands, and the most important one for what we're talking about tonight is anandamide. Anandamide binds to the CB1 receptors. It comes from the Sanskrit word for bliss, ananda, and it is the molecule that gives us a sense of well-being, you know, that everything's okay, of calm. That's what anandamide does naturally for us and all of our animal companions. 2-AG very much is focused on the immune system, so we really won't be talking about that tonight. And then the enzymes that work to create or degrade these ligands. So what is the function of the endocannabinoid system? And it's all about homeostasis, which would make sense, right? If it's embedded everywhere then it's coordinating and communicating. And to me, it's that communication that just fascinates me. You know, it would say there's an injury to the nervous system, then it's going to either, if the immune system's getting on board a little too early, it's going to say, okay, calm down. Or if we need more of the immune system coming on board, it's going to pull it on board. So to have this system that actually helps the entire body communicate with each other, you can see why, since I'm interested in holistic medicine, this is, you know, the epitome of holism. And there's something that you may read about in the literature called endocannabinoid tone. And it is really each individual's amount of how our receptors are doing, how the ligands are doing, all of that type of thing. The researchers have called that endocannabinoid tone. And I just want to mention this article briefly because it is about humans. Dr. Russo is a neuroscientist, MD, PhD neuroscientist for humans. And he started researching and finding that some of these weird diseases that humans get that are difficult to diagnose may actually be due to dysfunction or deficiency in the endocannabinoid system. Now, the reason I mention this is because I personally think that we may have some of these types of things in veterinary medicine. And as the research goes on, it'll be really interesting to see, like, feline lower urinary tract disease, maybe even feline hyperesthesia syndrome, things like that. It makes me wonder whether there's some type of deficiency or dysfunction in the endocannabinoid system. Okay, but we're here to talk about seizures and the nervous system. And the really interesting thing about the endocannabinoid system that you probably already know is that it is a retrograde mechanism. And it means that it is all about that communication and that calming. So you can see from this picture, a neurotransmitter is released, you know, like it would normally. Oh, you need me to slow down? Are you good? Okay. Normally, yep. Okay, you got it. So the neurotransmitter is released, and then it goes to the postsynaptic receptor. And that's where the ligands for the endocannabinoid system are released. And then those go on transport proteins back to the presynaptic neuron to influence it, and then back to the postsynaptic to be degraded. So the bottom line is that it is a feedback type of mechanism that is only brought forward when the nervous system needs it. Okay, so what are some of the functions of the endocannabinoid system within the nervous system itself? Because yes, it communicates with other systems. However, it has specific functions within the nervous system, and pain, modulating of those neurotransmitters, like we just saw, processing of memory and emotional memory, which is very important for people with post-traumatic stress disorder, because it helps to break the emotion from the memory. So working with the endocannabinoid system can be very, very powerful in helping people with trauma. It's really critical for sleep, for our ability to focus, and it is the primary neuroprotective mechanism that the nervous system has. And for that alone, I would invite you to learn about it, because it is very fascinating. It also regulates mood, neuroinflammation, neurogenesis, and then just some facts, you know, as we age, our CB1 receptors decrease. And interestingly, if you read any of the literature on neurodegenerative diseases like Parkinson's, the CB2 receptor is upregulated. And that's because, as we know, when there's degeneration, there's free radicals that are formed, there's inflammation. So that immune part of the endocannabinoid system is trying to help with that. Okay, so just for ourselves, there's different ways that we can support the endocannabinoid system, you know, decreasing our stress, yoga, exercise, eating well. And then we're going to talk about hemp and cannabis. However, I think it's important to know that cannabis is not the only plant that nature has given us to help with this system. So you can see eating cinnamon, turmeric, my favorite, dark chocolate, green tea, all of those things help to support our endocannabinoid system. Okay. Now, this is what we all came for. Let's talk about cannabis and the substances within cannabis that have medicinal effects, which are they're called phytocannabinoids. Now, there's much discussion about cannabis versus hemp. Cannabis, it's all cannabis. The definition hemp was given by the United States federal government in 2014 to describe the variety of cannabis that has less than 0.3% THC. Now, THC, tetrahydrocannabidiol, is that part of the cannabis plant that makes people and dogs high, euphoria. It is what created making cannabis illegal. So the government saw the usefulness of hemp, and if it has less than 0.3% THC, you are not going to get that euphoria that you would if you had more THC. Now, I think definitions and words are important, and I see this written even in the literature all the time. They will say that hemp is not psychoactive, and that's wrong. Hemp will affect the mood. People with depression, people with anxiety, animals with anxiety. Hemp will help to calm that anxiety. However, so that makes it psychoactive. It works on the psychology, the nervous system, but it will not create the euphoria. So just to get those terms right. Other things that are in the plant are terpenes, which are the oils within the plant that have their own activity, and then flavonoids, which are the antioxidants in the plant. And there's something called the entourage effect that you may read about. And it's really the basic idea of any kind of plant-based medicine, that all of the substances within a plant work together to do the healing. It's not just one part of the plant. So anybody that does plant-based medicine knows this. It's just that this term was brought forth for cannabis. So let's talk about some things, because this is really important to understand when reading the literature. And again, even in the literature, I'll point out in a little bit how the titles very often do not reflect what product was used in the study. And that just is frustrating to me, because, you know, we need to have the terms correct. If we have a general family veterinarian that calls us and says, I have a case of meningitis for you, and then the dog comes in seizuring, well, that's not meningitis, is it? So I think it is important that we get the terms correct. So There's something called full spectrum, which means it's the entire plant. So if it's cannabis, it's going to have whatever amount of THC it's going to have in it. If it's hemp, it's going to have 0.3% or less hemp, THC. Now there's other things in the literature called extracts or broad spectrum. And those are varieties that they'll take out as much of the THC as they can. So for example, I've used a product that it's less than 0.01% THC. It's all the rest of the hemp plant, but not very much THC. That's called an extract or a broad spectrum. Then, Then there are isolates, which is how they will remove one phytocannabinoid, usually CBD, usually with chemicals, so that it can be utilized or studied. So you're getting as pure an effect from one phytocannabinoid, and you're not getting the rest of the effects of how the plant works together. And then there's something called precision spectrum, which is blending different varieties of hemp or cannabis to create a product that has more of a certain profile that you want it to have. So just like this picture of roses, you have red roses, yellow roses, white roses. They're all roses, but they're different varieties. And the same is true. There's a massive number of varieties in the cannabis world. So Dr. Russo, I think, has it correct in saying that really cannabis medicine is very individualized. And I think we'll see that as we talk about seizures. You know, it really is who is taking what type of product, how it affects each individual person. It's very, very clear that it's individualized. Okay. Okay, this is key. Pharmacokinetics is key to understanding the research that we have in front of us, because cannabinoids are fat soluble. They're very hard for the body to absorb. So bioavailability, the ability for absorption, can be extremely limited. And many products that are on the market, only 20% of that cannabinoid is getting into the tissues where we want it. It can be from a first pass effect. It can be that it's just not absorbed. So the range of differences on how products are going to perform oftentimes has a lot to do with what type of product it is. Now, more and more companies are creating novel preparations such that they're absorbed better. And the one that I like to use, it's like an 80 to 90% bioavailability. That allows the client to use less, so it's less expensive and less side effects, because you're not giving massive doses trying to get it into the brain. And then there's other ways of administration, you know, sublingual, topical. They've even, I read in the literature, they're a company trying to create a transdermal product that absorbs and then could be used for seizures or pain. This is extremely important, and I think it's probably the first tip as our clients are coming to us. Again, it's all over social media. They're all interested in trying it. And this is a really key thing that we can ask of them or to help guide them. And that is the certificate of analysis. So the important point about cannabis is that it is a plant that detoxifies the ground. It pulls in heavy metals. It pulls in pesticides and pathogens. So we need to make sure that the product that we're using was grown organically. that doesn't contain nasty pathogens or heavy metals. And that is all going to be in a certificate of analysis. It will also tell how much THC is in that batch. So if it's a hemp product, it better be less than 0.3% THC. And the quality companies, you know, nowadays I can take my phone and scan a code on the box and bring up the certificate of analysis on that batch. So I can look at it and say, this is an okay product. It always should be done, obviously, by a third party, not by the company itself. So that's critically important, to have the clients find the certificate of analysis if it's something they want to use. There's a group in the United States called US Hemp Authority, and they're a group that brings the standards very, very high. So products that they recommend have gone through a rigorous process. You know that they're going to be good products. Okay, so what are some of the phytocannabinoids that are important? There's over 100 that are known right now. And so you can imagine there's more and more research coming out. The main ones that people talk about are THC and CBD. However, we're going to briefly mention some of these others because we're finding that they may also be important to seizure control. My very favorite is actually CBG, cannabigerol, because it is fantastic as an anti-inflammatory. So it also has anti-seizure properties, but I love it for those dogs that have really resistant arthritis. And there are many others that, again, are being researched, and we'll talk about a few this evening that are important to seizures. Okay, so before we get that, let's talk about what happens to the endocannabinoid system when a person or an animal is seizuring. Because if we don't know what it's doing, then what's the point of trying to work with it to help with the seizures? So in models of the acute model of seizures, the chemotoxic model, what will happen, whether it's studied in mice or rats, is that when a seizure is induced, the brain will immediately increase levels of anandamide. And again, remember, that's the product that binds at the CB1 receptor to calm everything down. And they've done studies where if you block the metabolism of anandamide or you block its reuptake, the seizure severity is reduced. So at least in this model, it seems to show that the more anandamide, the easier it is on the seizure. And then in mice that have less CB1 receptors for the anandamide to work on, they had more severe seizures. And there's a virus model that they use. Yeah, okay. You bet. Yep, I'll wait. That's okay. Okay, no, sorry, I keep speeding up, sorry. In this model where they create more CB1 receptors, oh, I can hear you too, yeah, which is okay, but more CB1, yeah, receptors, the severity of the seizures are reduced. So we know from all this work that something is happening when an animal seizures. Now that doesn't really fit with our patients though. We're dealing with chronic epileptic patients. So in studies of those, they're finding where they have mice or rats that have created chronic seizures, they're finding the same type of importance of the endocannabinoid system. It really suppresses that pathologic activity. It helps reduce the spread of the seizure. And just as we saw in the acute model, those CB1 receptors will either increase or decrease based on what the brain needs. So that's fascinating. The brain is doing that on its own over a period of time. So the question is, would chronic seizures create a dysregulation of the endocannabinoid system and then create more seizures, or does it have nothing to do with it? And this is primarily the brain's way of being neuroprotective. And it's just trying to calm things down. And in doing so, potentially the seizures are changed. And that's where more research is coming out. This is an interesting study that I really enjoyed reading. And so this was 40 idiopathic epileptic dogs and 16 healthy dogs. And it came from, they must have done another study where they did CSF analysis, MRIs, neurologic exams. So they know that these 40 dogs were idiopathic. And then later they went back and went to the saved CSF and measured their anandamide. And so what they found is that in the epileptic group, they did have higher levels of anandamide. And this is similar to a study that was done in humans where they took spinal fluid with people who are newly diagnosed with epilepsy. And they found the same thing. Those people had higher levels of anandamide. And it was also correlated with severity in the dogs. So if those dogs had cluster events, more than one seizure in 24 hours, or they had prolonged seizures, or dogs that seizured longer than 6 months, they had higher levels of anandamide. So it makes one think that the nervous system of the dog is doing something to try to either protect or regulate the seizures. Now, interestingly, they did not see a change. They also measured 2-AG. And if you remember, that's the substance that is more immune-based. So at least preliminarily, it's telling us that there isn't inflammation associated with these idiopathic epileptics. That's one way of interpreting it. Now, the downside of this study is it's kind of surprising that they didn't track how long after a seizure event they took the spinal fluid. Even in whatever the original study was, I find that surprising. So the downside is we don't know if dog A had a seizure 2 weeks ago or 5 minutes ago. So that's a problem with the study.
Can I ask you a question?
Yes.
So you're saying that in dogs with seizures, anandamide is increasing, and I wonder if that would be like a problem with treatment with THC, for example, because they are like competing for the same receptors, and THC is not like a complete agonist.
Mm-hmm. That's a great question. At least in the clinical work, there actually might be part of that, and we'll get to the biphasic response. So one would think, based on what the data show, that if the animal or person is making more CB1 receptors to help, that there's the anandamide's not going to necessarily be able to keep up. But I think that's a really good point. Although what THC does is it binds at the CB1 receptor longer. That's why it creates the euphoria. You know, naturally the anandamide binds, it's, you know, done in a split second and is degraded or whatever happens. But THC hangs around. So yeah, one could argue that if it's hanging around on that receptor, then the natural anandamide can't get to it. So I think that's a really good question that I have not read anything on that. But yeah, that's a really good question.
Thank you.
Yeah, thank you. So let's talk about then the specific phytocannabinoids. We now know the endocannabinoid system is doing something. Let's talk about the different ones that people are using and what data is out there. And I just wanted to point out this first study I thought was fascinating because this was done in 1949. It was like 5 people that they looked at cannabis and their effects, and supposedly had improvement with their seizures. And interestingly, it's a whole different topic, but in the late 1800s and early 1900s, cannabis was one of the most widely prescribed medications by physicians. They used it all the time for many things before it became illegal. But what we know from the research is that THC, again, as we were just talking about, it's binding at these CB1 receptors, but it's also being studied at other receptors. So that may be also how it's influencing things. These other receptors that we've talked about, the TRPs, even calcium channels. We know that THC is doing much more than just at that CB1 receptor. It appears to limit that toxic effect in the chemotoxic models. And then there's many rodent models that are out there, both chronic and acute seizures. And just in summary, they're all very different. So it can be tedious to kind of pull everything out. But in summary, in about 60% of the models, there was a statistically significant reduction in the seizures. And in about 30%, didn't do anything. And then you had these small percentages. In 3%, they worsened. We'll talk about that in a second. And 3%, it was kind of, sometimes they were better, sometimes they were worse. So, and I think it's interesting as we go forward, you're going to see this 30%, 60% keep coming back and back. It's really fascinating. Now, there was a study done in people. Dustin Sulak is a physician that has done extensive study on cannabis and uses it and teaches it. He and Dr. Russo are 2 of the experts in the field for humans. And what he looked at was a group of, these were all children. They had resistant epilepsy. So you can imagine, again, this isn't exactly mirroring our patients because many of these children had structural brain issues. But they looked at different things. Again, these were all plants, though. That's the important point. These were not synthetic extracts. They were plants. And you can see that whether it was CBD rich or with some THC, or now there's something called THCA, that's the acid form of THC. And the acid form in the plant occurs before the plant ages, or if the plant is heated, then it changes over to the regular form. And researchers at the beginning thought the acid form didn't do anything. And now they're finding that in and of itself, it has activity. So you can see that the numbers are variable, but in over 80%, almost 90% of the children, there was some effect, some reduction in seizure numbers, whether it was 25% or a complete response, meaning they hadn't seizured in a year. And also though, to remember that many of these poor children are seizuring 5 times a day, so a 25% reduction could really improve their quality of life. The remaining had no response, or they were worse. And again, we're going to talk about that in a moment. And that is, this worsening comes from something called the biphasic response. And this is unique to cannabis, unique to THC. And what happens is that as you increase the dose, it would make sense that you would get side effects. That makes sense. That's what we see with our medications. We increase the dose of phenobarbital, we take it too high, they're going to have a side effect. But in medications, the effect that we're trying to get, say, on seizures, doesn't get worse. It either stays the same or potentially gets better. But with THC, what can happen is if you hit a certain point, not only do you get side effects, but you get a worsening of what you're trying to treat. And that's this biphasic response. And so that's why you'll see in the literature, they got worse with being in the study. And it could potentially be from this. And it's mostly with THC, but there have been some reports with CBD as well. But by far and away, it's with varieties that have a lot of THC. And it tends to happen more with synthetic products versus plant, but not always. And interestingly, there was a study looking at this in different species. We know it happens in humans. We know it happens in rodents. But in this study, dogs were resistant to this. So yes, they got side effects, but they didn't get worse in what they were studying. So that's interesting. Okay. Now, in veterinary medicine, I'll just briefly talk about THC because it's so illegal. It's still in the United States, a Schedule I, meaning you cannot use it. However, it's amazing how as different states here are legalizing medical cannabis, clients are getting it and they're creating their own blends and giving it to their dogs and seeing an effect. So it's frustrating because we're the ones that should be guiding this and we're on the sidelines. However, in California, the veterinary medical board has just said that at least veterinarians can have a discussion about it with their clients, thank goodness. And Trina Hazza is an oncologist, and she in the veterinary world has done extensive study of cannabis. She really, really knows her stuff. And I'm sure she can't prescribe it, but somehow she has come up with a blend that she feels is safe and potentially effective for seizures. Now, you'll notice that it's a CBD THC blend. Why do we see those on the market? Because that is the most common thing you're going to see with any human that uses medical cannabis. They are usually using a product that is either a 1-to-1 blend of a variety that has a lot of CBD and a variety that has a lot of THC. Why is that? Well, it's because CBD blunts, it reduces that euphoria from THC. It's a complicated mechanism. It's not completely understood how, but it's independent of the CB1 receptor. So this is why you're going to see blends that have CBD with the THC. It's to blunt that euphoria so that as much of the effect of the THC can be had without the person walking around high all the time. And according to Dr. Hazza, her feeling is you never go above 0.5 of a total dose in a dog of THC. So obviously we need more and more work to follow this. And I think it's something where when we're having a conversation with owners, you know, I don't even go there. I just feel like stick with CBD for right now. There's just too much around this. Okay, so let's go on to CBD because that's what we're seeing for the most part. And its mechanism of action is interesting and it's still being studied. It's not as clear as THC. It does have some indirect effects on CB1. It changes the amount of anandamide in the brain. And it also works at different receptors, GPR55, and some of the other ones that I mentioned, along with potassium and sodium channels. So more and more needs to be understood about how exactly CBD is working on the brain. So what do we know about its effect on seizures? Most of the work has been done with synthetic, maybe called, you may read it in the literature as purified, meaning it's synthetic. So they've worked with the plant. You're not getting that whole plant. You're getting a synthesized version of it in usually a lot of a carrier oil, oftentimes coconut oil, or another medium chain triglyceride. So we even have to wonder, is there an effect from the carrier oil? Although most of the good studies obviously are going to have a control group that just gets the carrier oil. And in rodents, they found that when they use this purified CBD, that they'll work with in vitro and in vivo. And so it'll reduce the seizure activity in brain slices. And then again, in these acute and chronic chemotoxic models, the CBD will reverse or reduce the severity and death that occurs for some of these acute models. So we are getting some research to say there's potential there. Now, the most famous studies, and they're up to at least 4 now, on the FDA approved medication, Epidiolex, which again is a synthetic CBD product that was developed for children with very treatment resisted seizures. And again, the population is different than what we see because most of these kids have a neurologic structural disorder. And so it's a little bit of apples to oranges. However, they did find that the Epidiolex was effective in reducing the seizures, again, in a statistically significant way. And yet there was a lot of side effects. There was, up to 80% of these kids, because probably of the oil and the amount that has to be given because of the bioavailability, they're tired, sleeping, diarrhea. They did see an elevation of liver enzymes that reduced once the medication was stopped. Another similar study, again, looking at a synthetic CBD, but in children and adults with resistant epilepsy, they did see this reduction. This tends to be this 30% reduction And you read that in a lot of the literature, and I find that interesting. But again, for some of these children where they're having so many events, that can be significant for their quality of life. But interestingly, in that cutoff that many of the researchers want to see a reduction by 50%, not that many do that. Some do, but not the vast majority. In this study, one patient ended up being seizure-free for 12 months. One had that biphasic response and actually got worse with their absence seizures. Okay, in a study where they wanted to compare these purified CBDs to plant-based CBD, there was some interesting data. And again, this is in people where they found that a reduction in 70% reduction with the extracts versus which is an extract, a plant-based extract, okay, versus the purified. So that's a pretty big change, which was statistically significant. Interestingly, again, about 39% reached that 50% reduction, but it was similar in the control group and the treatment group. And that is something you'll see as well. So it almost makes you wonder, you know, if just doing anything changes what's happening in the brain. But interestingly, and this was the main point of the article, is the side effects. And they found that in mild side effects, they were really over doubled in the synthetic group and tripled with the severe side effects. So I think it just gives some good information that we should not give up on plant-based medicine. Okay, we're almost done. The one trial in veterinary medicine where they looked at epileptics, I'm sure we've all read it. So I'll just summarize, but these were refractory, difficult, idiopathic epileptics. And they did use a natural product. It was hard for me to tell when I researched the product how much THC is in it, because there's discussion among cannabis treaters as to, even in the hemp world, does that 0.3% THC make a difference clinically? And we really need some good research to show that, because it's very anecdotal. And I could not tell from researching this product exactly how much THC. They did measure some in the blood, so that tells me there was some there, potentially up to that 0.3%. So it's a small group, as you may remember, and they started with 12 in the CBD and 14 in the placebo, and lost a few dogs. One had status, another got too much ataxia, others just couldn't return for follow-up. So again, the group ended up being pretty small. But what they found, again, here's that kind of 30% range. They found that reduction in the CBD group. But again, it's same level of 50% reduction in both groups. 2 dogs in each group went down to a 50% reduction. Interesting. They did find that there was a correlation. So when they measured the plasma, you know, obviously the more CBD in the plasma, the better control that individual dog got with their seizures. They did see an increase in liver enzymes, just the ALP. However, that did not change the metabolism of the other medications the dogs were on, because again, they were resistant epileptics, so they were all on more than one medication. Here's where I was a bit frustrated with the study, and I actually have emailed Dr. McGrath. I haven't heard back yet. It always is frustrating to me when there's a control group of epileptics against another group of epileptics, because there's so much variety. I think we all know that. But they measured a cluster event. So if the dog had 4 seizures in 24 hours, in the data that was measured as one event. And so in my mind, though, with all the years of treating these dogs, I feel like I've had some success if I can get them not to cluster. So if I can take an animal from having 4 seizures in 24 hours to 1, I'm happy. So they did not tease that data out. I would have loved to have seen that. And maybe they didn't because there was no difference. Maybe the cluster dogs stayed as cluster dogs, but I would love to know that. I'm hearing through the grapevine that they're working on another study. So we'll see what comes up from there. Okay, so all this comes down to, and this is purely my sort of opinion, so you can take it for what is worth. Here are the things that I have a conversation with my clients or people, veterinarians who might come to me. Number one is the product. In this country, there are products that I trust. They have a good certificate of analysis. That may not be the case where you all are. So making sure that that client gets that certificate of analysis is critical. And then looking at products on their bioavailability, which is common sense. I don't want a client to spend $300 a month adding in some type of hemp or CBD. If we really felt like it was going to help, well, maybe, but a lot of it is really looking at the whole picture. How much is it going to cost? And is the product going to give them a lot of side effects? So those are the discussions that I have with people. But from the standpoint of purely the neuroprotective effects, I find that if a client wants to use it, it's a high quality product, they don't have to spend a lot. I feel good that dog is most likely getting some kind of neuroprotective effect. Now, what does that mean for the reduction of the seizures? We don't know. Again, it's so individual, but I feel like the data shows us there's the potential for the reduction of seizures. So when I'm talking about this, again, it's very individualized, which is the case with every epileptic we treat, right? We all have to look at each animal and family as individuals. My kind of flow chart, my focus is that if the dog or cat is seizuring to the point where it's so infrequent that I wouldn't start a medication anyway, I have no problem with the owner doing a high quality CBD product. They may get some neuroprotection, and maybe as we track these patients, it may go from 1 seizure every 4 months to they haven't seizured in a year. We don't know unless we track it. So I don't have a problem with that. What I will not do is if they are seizuring enough that I'm normally going to start a medication, they're going to get a medication. I'm not going to say to a client, oh, let's do CBD instead of whatever medication I would choose. I just don't feel comfortable enough yet with doing that. Now, having said that, Ronaldo was kind enough to share the study from Denmark that showed these epileptic dogs that weren't treated, and some of them got better for a long time, some of them didn't. Again, it's so individualized. but I feel like it had in integrity for where we are as a college, as a group, we have to stick with doing it in the safest way that we can. Now, if I start a medication and they also want to start, you know, a hemp product, I'm okay with that. And then let's say they do, I'm going to treat that like any medication. So many clients will want to do that and they'll, okay, then let me take it off of the medication. No, I'm still going for the basic goals that we all go for, which is, you know, stop the clusters, increase the time between seizures, a good quality of life for everybody. I'm still looking at it that way. So let's say that dog or cat is now gone many months and is doing great. Just like anything else, I might consider reducing one of the medications that they're already on. But it's only within the parameter of how we were all, I believed, all trained to do this. So that is how I approach it. Just to give you what's coming up, there's more research on these other cannabinoids because they're all showing some effect, at least in rodent models, to help seizures. So there'll be more and more coming as we go forward. Okay, so happy to answer any questions if I can. If not, I'll try to find you the answer.
Thank you very much, Sue. Really appreciate. Great presentation. Pessoal, vamos abrir para perguntas. Marília, pode fazer a pergunta em português e você traduz para ela? Agora eu mudei para o canal em português. Tá. Eu acho que sim. Você quer que eu... O que você prefere? Que a pessoa faça a pergunta em português para ela? Você quer que eu repita a pergunta em inglês para você? O que você acha melhor? Então, você pode fazer a pergunta em português e você faz a tradução. Beleza, gente. Vamos lá. Quem tem pergunta? Que perguntas para a doutora Wagner?
So I just have a question. Like, in your opinion, Dr. Wagner, I know it's not legal, but in some countries it is to use THC. So do you think it will be like something interesting to try it, like a combination of both in epilepsy? Because of these cases that when it worsens epilepsy, I'm kind of worried to try it, but
Yeah, well, and yeah, good question. And at least from the one study that they did, they didn't see other problems worsening in dogs. They didn't see that biphasic. If somebody, I do actually know a person who was already on a combination of THC and CBD with her dog that has epilepsy. And the dog, it had head trauma. It's so refractory. Nothing much is helping that dog. However, I do think that in those cases where, yes, things just aren't, you want to try it because that dog is suffering. I think going with Dr. Hazaz's recommendation, I trust her because I know how much she has studied this. And so I would say to the client, you know, I know you may want to do the 1-to-1. I would prefer that you get a 30-to-1 CBD to THC, you know, and start very slowly. And actually, that's a good point too. Even with CBD, there's some great research that shows when you start very slowly at a low dose, the brain actually and the nervous system actually makes more CB receptors. So you're helping it to get going, plus just, you know, minimizing any side effects. So yes, I do know people who have done it. I know people, you know, this dog did fine, and I know others who have used it and their dogs have been fine. It's just, I would trust Dr. Hazza and use the least amount that I could use and go really slowly, because we know from the research that even if they get too much, they will have the static ataxia, you know, and then you back them down. Again, unless they get into a stash, which is a whole different, you know, toxicity. But in a normal dose, as you escalate it, if you start to see that they're too tired or they're getting the ataxia, you back it down. So yes, I do think it can actually be used.
Thank you.
Thank you.
Wagner primeiro, depois a Julia.
Ronaldo, por gentileza, traduz para ela o seguinte: no estudo que ela apresentou em veterinária, medicina veterinária, houve uma redução maior de 50% das crises éticas, tanto no grupo placebo quanto no grupo tratado. E no tratado. Então, a minha pergunta é se estivéssemos falando de uma substância farmacológica, uma nova droga, alguma droga nova, que tivesse o mesmo nível de efeito no placebo e no tratado, será que nós teríamos tanta diligência em tentar utilizar essa substância quanto estamos fazendo nos canabinoides?
É isso?
E será que com essa postura a gente não está simplesmente tentando ir de encontro a uma vontade, entre aspas, epidêmica dos proprietários em tratar os seus cães com canabinoides?
Tá. Marília, vou repetir em inglês para ela, tá bom?
Não faça aí.
Question from Dr. Wagner Shamal is, in that prospective study from Colorado, the responder group, like those with like 50% or more reduction in seizure frequency, was similar between the treated group and the placebo group. If we weren't talking about CBD, we were talking about whatever, like a new anticonvulsant, like using humans, like one of those valbamate like drugs. Do you think we would be still pushing for more studies, or just kind of giving up on that and moving on? And following up to that is, do you think that the fact that we're just kind of like pushing more and more studies, like CBD related studies, more like to basically because of popular demand, of like the popularity of CBD based therapies, and like how popular, like all like the news kind of on children that were super refractory? I mean, what's your take on that?
That is a fantastic question. And I think I couldn't agree more. I think there's a couple of different levels here. Number one is kind of my theory on the 50, if you set it at 50, let's start here. If you set it at 50% is what we want, that as a community, we say, look, we really think if it's worth looking at, we should get a 50% response, then I would agree, like, hello. However, I think we also have to look at, in some of our patients, a 30% response changes their quality of life. So that's where it becomes very individual. And I think that that's why I really wanted to see that data teased out on the clusters, you know, because I want to look at this from a standpoint of, yeah, it might be a 30% reduction, but that made a significant difference in that dog and that human's life, because the dog wasn't ending up in the hospital with a $4,000 bill. So I think it's the endpoint that we want as a community. That's how I would answer that. And I would still think that in some of these tough cases, or even some of the cases where they're not refractory, that's where we need the outcomes. You know, I'm trying to work with a couple of companies that, you know, I know the product, I want some outcomes. You know, I think that we're all in this, we have common sense to know an idiopathic epileptic when we see it. You know, if Ronaldo says, I've got 5 idiopathic epileptics, I believe him. I don't need an MRI and a CSF analysis to know that. And I think that we need to evolve a little bit to get to that level. And I want some outcomes. Every evidence isn't a randomized controlled trial. So I'm actually behind the scenes trying to get some of those outcomes for us. Like, okay, here's this one product. You say it works. I want to talk to 20 clients and I want to know, did they get in maybe a dog that isn't as refractory, did they get a 50% reduction? Did they get a 60% reduction? We don't know that yet. I think that we do see that, but the research has got to get better. So I do think it's worth continuing. And also, part of me too, when you see these kind of things, is I think there is a placebo effect with the client, whether you put them on phenobarb or CBD, or I don't care, you know, and even in that placebo group, it's like, ooh, my dog may be on this new substance, so I'm going to relax. And there is the study out that showed that when the owners of the epileptics were more stressed, it changed the dog's seizure patterns. So I think there's a huge placebo effect. To me, when you put them on anything, I don't want to know for a month of what's happening. You know, I want that stress level. I want the owners to kind of get back to normal, and then I'll start measuring it. So, so I think there could be some of that going on as well. So I hope that answers the question. I do think it's worth going forward and looking at dogs that are less refractory. I really do think it is. And we need some doggone outcomes to know whether it's worth going forward. So I'm trying to get them.
Thank you.
Yeah.
Julia.
Ronaldo, você traduz para mim, fazendo favor, a pergunta? Existem alguns pacientes que eles periodizam as suas crises, por exemplo, de 21 em 21 dias, em 43 em 43 dias, e eu tenho adotado uma prática que, como a gente tem um calendário de controle das crises, eu costumo entrar um dia antes do dia que teoricamente teria uma crise, no dia e no dia após uma dosagem maior para evitar essas crises. E em 7 pacientes, eu já tenho um resultado de não ter crises com esse aumento de dose no dia que antecede, que antecederia no dia da crise e no dia após. Você conhece algum tipo de prática semelhante? E eu queria sua opinião a respeito desse tipo de terapêutica, utilizando a cannabis.
So the question is, you know that there are some epileptic dogs that they seize according to a specific kind of sort of timeline, every 21 days, every 42 days,
Oh, yeah.
moon phase, whatever.
Yeah.
Dr. Julia was saying that she has started to use in 7 patients or more patients, but 7 patients that seem to have responded to it, that she basically doubled the dose the day before, when she believes that that's kind of according to the seizure calendar, that they will have seizures, once or more seizures. So the day before, the day off, and the day after, like a higher dose, let's say twice. And she was asking if you are aware of any sort of protocol like that being used or established, and what's your take on that?
I've not read where anybody has documented the protocol in writing, but I certainly know neurologists that do that, and I think it's brilliant, especially because those doggone dogs that are once a month are, yeah, you can just count on that they're going to seizure at that 21 day, and you know, if you can change it at all, especially if they're a cluster dog. You know, it's interestingly, because if you look at it from purely the pharmacokinetics, it shouldn't make any difference, right? It should take several half-lives to get that level up. You know, same with the rescue. I've always wondered, wow, you know, they had a cluster and then we gave them a whole bunch more medicine for 3 days. Are we really doing anything? Because from a pharmacokinetic standpoint, it shouldn't have raised their level. However, I think it goes back to there's these subtleties that the brain has that we see clinically that for whatever reason, it works. So there must be some other mechanism besides the pharmacokinetics of it. Is it reducing the owner's stress, or is it just calming the brain enough? That little extra is calming the brain enough that when that trigger happens, it doesn't completely, you know, seizure. So I do know other people doing that type of thing. And I, you know, if it works, I say you go for it. Yeah.
Along those lines, there's a question in the chat, but do you know the half-life and the, I mean, the time to reach steady state is always 5 half-lives, but do you know, I mean, do you know the, let's say, depending on the pharmacologic preparation, like the oils that are used, like what is the expected half-life, or better saying the range out there? Like you just said, that starting the day before, in theory, wouldn't change anything from a pharmacokinetic standpoint. What do we have in terms of pharmacokinetic of CBD related products?
Yeah, most of them have pretty short half-lives. You know, I think like 5-6 hours, even the couple that I think I read. So they do recommend that twice a day. And some of them, when you look at the pharmacokinetics, really should be 3 times a day, but you're getting into cost and side effects and things like that. So the ones that I've read about are more, you better do them twice a day. The one that I've used that has the really good bioavailability on one of the pharmacokinetic curves, it had a long, I mean, it was at 12 hours, it was still very, very high. So I actually start that one once a day because it takes 24 hours to come back, that whole area under the curve to come back. But in a couple of dogs where their seizures were still happening, I had them go to twice a day. And honestly, it's just been a small number of dogs, and I haven't seen a huge change. I haven't seen that 50% reduction in the refractory dogs. I've seen more of that. Have not. I've seen more of that 30% reduction area, you know, which again, we have to decide in a quality of life. What does that mean? Now, dogs that aren't so refractory, that's, you know, there's one, and again, from that study in Denmark, who knows what this means, but it had a couple of seizures, what I would consider a cluster, MRI, some cortical atrophy, but waited, obviously weren't going to start treating to see when the next event was. She decided to do CBD. That's been 3 years ago. The dog's never seizured again. Now, we could go, it wasn't going to seizure again. But really, when we think about it, how often do we see that? It would be rare for a dog not to, we're going to be telling the owner, oh yeah, they're going to seizure again. So anyway, the long answer is, yeah, most of these products need to be twice a day for sure. Yeah.
And in that particular case, being seizure-free for 3 years,
Yeah.
after 1 year or a year and a half, 2 years, you didn't try to stop it?
The owner didn't want to. Yeah.
Oh, didn't
And
want to.
also, I wouldn't have, just because of the MRI diagnosis of some mild cortical atrophy. So purely from a neuroprotective effect, I thought, well, this is good. But I think that it would be interested, if she's a veterinarian, she might be open to a little trial of getting the dog just on a regular antioxidant for that cortical atrophy. That would make me feel better, and her, and then weaning the CBD. Yeah, I don't know if she'll be open to it. I would love to see it. Yeah, I'd love to see it. Yeah.
Pessoal, mais alguma pergunta? Um comentário? Não estou vendo nada escrito no chat, nenhuma mão levantada. Bom, assumindo que não temos mais perguntas, quero muito agradecer a gentileza da doutora Wagner de atender nosso convite, né, para falar para a gente sobre esse tema tão em voga no momento, né, tão discutido, tão debatido. Eu acho que para a gente evoluir, a gente tem que ter a cabeça aberta, ouvir a opinião e a experiência de pessoas que trabalham com o assunto e tentar, né, ela comentou, o grupo do Colorado está fazendo um estudo, né, esperar a evidência, né, e agir de forma cuidadosa e responsável, né, como ela mesma comentou, né, então, vocês devem ter ouvido como ela aborda esses casos, né? Então, de novo, nós todos da ABNV, nós somos muito gratos à participação de todos vocês, esperamos contar com todos, né? A gente está finalizando as últimas etapas da preparação para o nosso simpósio em setembro em Curitiba, e esperamos contar com a presença de todos vocês em Curitiba também. E aproveito também já para falar, e vocês vão ver nas redes sociais, que amanhã é o aniversário da fundação da ABNV, que aconteceu também em Curitiba, no congresso da Anclivepa. Então, o Dr. Alexandre Mazante já preparou, estava preparando uma comunicação que vai ser divulgada amanhã, e, obviamente, a gente fica muito feliz, né, da ABNV ter começado tão pequenininha naquele congresso e hoje em dia ter tantos associados. Em relação à data, nos dias 9, 10 e 11 de setembro, semana ali do médico veterinário. Tá bom? Em breve todos vão ficar sabendo, não é só questão, a gente só está finalizando várias questões em relação ao patrocínio e está todo mundo trabalhando. O Dr. Vitor hoje está em comunicação com ele está em comunicação com as empresas. A gente quer tentar fechar tudo isso antes de divulgar o evento e abrir inscrições, tudo, mas pode ter certeza, está todo mundo trabalhando bastante para fazer isso o mais rápido possível. Dr. Wagner tem comentário, por gentileza?
Ronaldo, eu queria só fazer um comentário, dessa vez a favor do Cannabinoid, né? Quando a gente fala, e gostaria que você traduzisse para ela, quando a gente fala em epilepsia idiopática, a gente fala de tudo aquilo que a gente não sabe a causa, e não necessariamente de um grupo uniforme. Então, se ela acha que eu tenho esse pensamento, que talvez os canabinoides possam ser úteis em um pequeno grupo de epilepsia, e talvez nós estamos olhando para um grupo muito heterogêneo. O que ela acha dessa proposição?
So, again, a question slash comment from Dr. Wagner. Like when we talk about idiopathic epilepsy, we talk about a very diverse disease, which, like, being honest, we know very little about, very breed specific, age specific, like lots of variables. And perhaps in a subset of these idiopathic epileptics, like CBD-based therapies could really make a possibly very impactful difference. What is your opinion about that?
I would agree. I think that's why I'm still so interested in getting more outcomes, because I do think there may be a subset where it does work better than another subset, something that's less refractory or, yeah, I would agree. I think that we just need more data. And I'm hoping to track some of these things and see, because I also know anecdotally of a dog that was seizuring once every 2 weeks, was put on a THC CBD blend by the owner, and then went 4 months with nothing. Now you could say, yeah, maybe it was going to do that anyway, but it had a pretty rigorous pattern, and so it's those cases that make me go, I don't want to give up on this yet. I would agree. I think we just need to keep digging and get more outcomes and look at the different blends and the different types of, what is it, a big dog? Is it a little dog that maybe has, as we discover even more about what an idiopathic epileptic is. Yeah, I agree. I think we just need to keep going and keep studying. Yeah.
And just a question for my own knowledge and to share with everyone.
Mhm.
Do you know if that group from Colorado, if they're planning to enroll a larger patient population? I mean, I know they had for a small study, a decent number of dropouts, but I mean, let's be honest, 9 and 7 is
pretty low. Yeah, that's
very,
to me, it's a
very,
pilot
very low.
study. Yeah, it's a
Yeah,
pilot study.
that should
right.
have been seen as a pilot. That's
Yeah.
very like limited numbers. Do you know if they're going for, like, I don't know, at least 20, 30, 40, 50? I mean, obviously that should have been based kind of like
Mhm.
a priori stats and kind of, what's the number to really reach like that 50% reduction, like equal or higher than that. I would guess that we're looking at, like if you look at other papers, 60 to 100, but do you know if they're aiming for like a larger patient population?
I would hope so, and I'll reach back out again and ask. And also, I think for the group, I would be interested in how everybody feels. You and I were kind of talking about this a little bit too, in that getting these trials, again, when you have to when you don't use the dog as its own placebo, you've got to have more dogs. And I think there's so much variability, common sense wise, to me. Just from a common sense, I go, I don't know that I want to compare these two groups. I want to know what the dog did a year before. I want to put him on the CBD or THC or whatever. I want to wait a good month, if not a little longer. And then I want to see what it does for the next year, and given there's even variability in that, then I want to see how many of those dogs go down 50% or 30% or whatever. And then I think the other piece of it to help us get more data goes back to, even when I was still a young buck doing the research, it's like, oh, you got to have the MRI, you got to have the CSF tap, you got to prove to the people reading the article that it's an idiopathic epileptic. And I would hope that we've evolved. Maybe this is controversial, but I feel like we've evolved to a place where we know, for the most part, what the heck an idiopathic epileptic is, and think of how many more dogs we could enroll if the owners didn't have to anesthetize them for an MRI or CSF tap or whatever. So I think it's thinking a little more broadly, bravely maybe, and trusting that if you tell me you've got 50 idiopathic epileptics, okay, maybe one slipped in that has a little malformation, but it ain't going to be 10 or 20, you know? So that's a little more controversial, but I think that's the way we progress and we go forward and we get the data, is to, you know, and do some retrospectives and believe what we know as good neurologists. You know, we know what's going on. So I think it's and I will ask, and I will also keep you guys in the loop if I can get this sort of retrospective going with this one company that, or a couple of companies where I can really get some data. Okay, because most epileptic clients that have epileptics, they keep a good seizure log, you know, and so let me have that retrospective data and see if it's worth anything. So I'll keep you posted if I get anywhere on that too.
Yeah.
So,
And I'll share with the group.
yes, that'd be great. That'd be great. So,
Pessoal, mais alguma pergunta, comentário? Bom, então, mais uma vez, agradecer a presença de todos, agradecer a gentileza da doutora Wagner em colaborar conosco, né, todos os membros da Associação Brasileira de Neurologia Veterinária. Mais uma vez, todos nossa diretoria, muito agradecido por vossa participação, vosso apoio e por prestigiar a doutora Wagner falando para a gente de Columbus, Ohio. Sue, thank you so much. Thank you for your kindness. Thank you for your time, for your experiences, for your willingness to, you know, kind of be kind enough to be able to share with us all your knowledge and experience kind of on somewhat of short notice. So we're very, very grateful.
no, and I'm grateful that everybody's interested and you invited me. So, so wonderful group, and I really appreciate being here tonight. Thank you.
Okay. Thank you very much.
Yeah.
Have a great evening.
Okay, bye
Muito
everybody.
obrigado, pessoal. Muito obrigado, pessoal. Boa noite, bom descanso, boa semana. Tudo de bom. Tchau, tchau.